for today's class is Pterygium, and I'm Dr. Divya. I thank Dr. Meena Lakshmipahy ma'am for moderating this class. And today we are going to see what is pterygium, the risk factors for developing pterygium, pathophysiology, its morphology and histopathology, presenting complaints, evaluation, management, and complications of surgery, recent advances in the management of pterygium, and frequently asked questions. Basically, pterygium is classified under conjunctival degeneration. It's rather a proliferative lesion. It is described as a fibrovascular overgrowth of the subconjunctival tissue, seen as a triangular or ring-shaped lesion encroaching upon the cornea. The risk factors for developing pterygium. It's a Greek word. It's a Greek word. Pteri means wing. It is in the shape of the wing, so it is called pterygium. Risk factors for developing pterygium. Prolonged exposure to sunlight, the UV rays in the sunlight, hot and dry weather, wind, dusty atmosphere, immune mechanism, genetic predisposition, and the chronic environmental irritation are the risk factors for developing pterygium.
Belt? Is there an environmental belt?
Yes, ma'am. Tropical regions are more.
So in India, do you think there is an environmental belt?
Yes.
Has anybody read anything about that?
Actually, there is a study.
Whatever you studied, you tell.
I didn't quote the study, but I have read.
It's okay, whatever you know, you tell.
There is a study conducted in the state of Andhra Pradesh where they have concluded that it is more in the southern region of India. The prevalence of pterygium is more because of the climatic and the atmosphere.
So it's a significant thing. So you will see a lot of Andhra patients we are in the border of Andhra, right?
Yes,
A lot of them do come with pterygium. So that exposure to sunlight in particular areas, hot and dusty, and one seems to be really true.
Yes.
How do you differentiate what kind of lesion is pterygium? What is it? You said it's under?
It's a conjunctival degeneration.
It's a congenital one.
Conjunctival degeneration.
Okay. So can anybody tell the difference between degeneration and dystrophy? First years. All questions here only to first year. Pterygium is a very basic topic, so the first years will answer this. What is a dystrophy and what is a degeneration? If you're not answering, you will have to submit a written explanation of what is a dystrophy and what is a degeneration. Not a very, very tough scientific talk that we are having today. She's introducing a very basic topic to all of you. You'll be seeing this day in and out.
Ma'am, dystrophy is abnormal growth and degeneration is
corneal dystrophy and corneal degeneration. I'll go like that. I'm sorry. Systemic dystrophy is. So write it down. The MLY asked this question. All of you submit. So doctor, can you answer this question?
Degenerations are usually unilateral. Dystrophies are usually bilateral. Ma'am.
Okay.
Degenerations occurs occurs at any age, ma'am.
Okay.
But dystrophy usually seen in the older age. As the age increases, dystrophies. I changed.
Yes. So
dystrophies can be seen in any age. Degenerations usually occurs in the elderly.
Basically, dystrophy is seen as bilateral, symmetrical. Okay, but degeneration is never bilateral and thing, and they have a genetic predisposition in dystrophy. Degeneration doesn't have a dystrophy. But I want a better pathogenic answer from you guys. Okay, first is you'll write this difference and submit it. Okay.
The pathophysiology behind the development of pterygium. Not all those exposed to sunlight develop pterygium. Only those susceptible persons with limbal stem cell deficiency develop pterygium. These persons with
so it's only hypothesis, doctor. Don't say as if it has been proven. Okay, limbal stem cell insufficiency is just a hypothesis. Nobody really has proven the why one person doesn't get and why the other person. So when you write this answer in the exam, just say it's hypothesis. It has been hypothesized as 1, 2, 3.
And the persons with pterygium, pterygium is seen in persons with less limbal stem cell reserve, and those patients are on exposure to chronic exposure to UV rays in the sunlight develop certain changes. That is this limbal stem cell deficiency on chronic exposure to ultraviolet rays in the sunlight triggers the factors, tissue growth factors like matrix metalloproteinases, tissue inhibitors of matrix metalloproteinases, and certain other cytokines, interleukins, which leads to the formation of pterygium.
There are three hypotheses that you have. So remember these three hypotheses. One is there's a possibility of limbal stem cell insufficiency in that area. There is activation of tissue growth factors because of some injury, and there is a tumor suppressor gene which is getting mutated, and matrix metalloproteinase inhibitors are there in these patients.
And these patients,
What is a precursor to pterygium?
pingicula.
So one of the things that we should mention is some of these patients have pingicula, which sometimes you will see in 10 years when you sit in an OPD. Many patients will come and tell you they had a small growth in that area. Okay, that's a pingicula. Pingicula in certain cases seems to be a precursor. Not all pingicula becomes pterygium, but there seems to be a few number of patients.
Going to the morphology, the parts of the pterygium, and I will be describing each now. This is the cap. It is the progressing edge of the pterygium. It is separated from the head by a avascular halo zone, and this is the head. It is the it is the part which connects the neck and the cap, and this is the neck. Neck is seen in the limbus. It is connecting the body of the pterygium with the head, and the body, which is the main bulk of the pterygium, and it is the communicating part of the pterygium with the conjunctiva. Stalker's line. It is seen in most of the pterygium patients as subepithelial brown pigmented vertical or punctate lines. Punctate lines seen at the edge of the cap, and fuchs flex. These are discrete white subepithelial conjunctival cells seen separated from the head of the pterygium, and these fuchs flex are not in connection with the pterygium. They will be seen separated from the head of the pterygium.
They're thought to be as nests, isn't it? Some of those papers will mention these are nest cells, which actually mean that they are active. I'm not sure if they're active, but they mention it as being active. So can somebody tell what is the appearance of the blood vessels here? How do these blood vessels appear? Just tell whatever you see. It's not something that I will scold. Just tell, how do the blood vessels appear? They are prominent. Are they prominent? Yeah. Are they prominent, and they are what color are they? Yeah. So they are prominently red, and are they very tortuous? No, isn't it? They follow along the course of the body of the pterygium. Okay, the importance is when you see in ocular surface neoplasia, what will be the blood vessel there? Somebody can answer there. They will be corkscrew. They will be turned around. They'll be twisted. Here you actually can see a loop. There will be an afferent loop, efferent loop. They'll go in and come out also. Some of those blood vessels you can actually see they loop and come out. It's just they don't stop there.
Histopathology. The pterygium, histopathology of the pterygium shows, as I mentioned earlier, it is a fibrovascular stroma with allostatic changes with the goblet cell hyperplasia, prominent feeder vessels, and subepithelial dilated vessels. The hallmark is the Bowman's layer fragmentation, which helps in the penetration, invasion of the conjunctival tissue into the cornea, inflammatory infiltrates in the epithelium, and loads of polymorphonuclear leukocytes in the vessels. It is called elastotic changes because they stay same as that of elastic fibers, but they are not degraded by the elastase. So they are called elastotic.
No, in an area where there is no elastin, you will find elastoid degeneration of the collagen there. So the wavy appearance of those fibers is what is described to be features of pterygium. Wavy fibers, elastoid degeneration rather. What is the other significant structure in our body which develop elastotic changes to UV exposure?
Skin.
Commonly it's seen also in skin. So they're akin to skin, which again has fragmentation of collagen. Even this.
This
Which staining you will use for histopathology? Fast staining is generally mentioned for membranes, for Bauman's layer, for Descemet's membrane, for membranes. You will see hematoxylin in use in stain only. That is a stain that is used to see all collagen. So
Oh,
when you send a tissue, when your consultant is operating, you need to mark all these things: what stain you want, what tissue you're send. Then only they will do that thing. You can't just say Congo red and send a pterygium, right? You have to mention all that.
uh, pterygium is mostly seen in the nasal aspect, though it can be seen bilateral. Most commonly, it is nasal. There is a proposed theory that it is because of the prominent nasal bridge, the divergence of the light rays falling on the temporal limbus is dispersed than compared to the nasal limbus, where it is focused more on the nasal limbus. But it is not proven. The study conducted by King and Smith et al. Proved that the peripheral light focusing theory is not the only mechanism behind it. It might be because of the anatomical features like temporal eyelashes bowing more on the lateral aspect, and the nasal tear flow, temporal to nasal tear flow, and the arterial supply in the nasal aspect, causing hyperemia and more blood flow on the nasal aspect. Symptoms: most of the patient present to us with the curiosity what it is there in their eye, cosmetic blemish, and the visual acuity. If it's a large pterygium causing higher astigmatism, they will come with a defective vision. And the ocular surface problems, since there is a surface alteration, it will cause Delenn formation, dry eye symptoms, irritation of the eye, foreign body sensation, and lacrimation. Evaluation: comprehensive ocular evaluation is needed. Visual acuity to assess the astigmatic effect of the pterygium. Extraocular movement: is there any restriction in the movement because of this pterygium? Anterior segment evaluation: location, size, and vascularity of the pterygium to decide about the treatment management part. Extended area of the corneal involvement. Detailed refraction, Schimmer's test to or tear film breakup time to assess the dry eyes. The types of pterygium: there are two types of pterygium, atrophic and progressive. Atrophic, it will be thin, papery, attenuated, poor vascularity will be there. It will not progress. It will remain as such for longer duration. Progressive, it will be bulky, fleshy. Vascularity will be more. It will be growing faster towards the center of the cornea, resulting in symptoms, resulting in patients approaching the clinician early. Biheaded pterygium. Pterygium may be biheaded in the same eye. It can be unilateral or bilateral, and in the same eye, nasal or temporal, both can be seen. Staging of pterygium. Staging based on the morphology. The midpoint between the pupillary margin and the limbus is taken as a point to segmented as three. If the pterygium is progressing beyond the pupillary margin, it is the grade 3. And if it is beyond the midpoint between the pupillary margin and the limbus, it is grade 2. And if it is between the midpoint and the limbus, it is grade 1. Staging based on the size of the pterygium. Based on the size of the pterygium involving the cornea from the limbus, assessed on the slit lamp examination. It is graded as 1 if it is 0 to 2 mm. It is graded as 2 if it is 2 to 4 mm, and graded as 3 if it is more than 4 mm. Trans staging. Based on the transparency of the episcleral vessel seen under the microscope, it is graded into 3. Grade 1 pterygium, it is atrophic pterygium where the underlying episcleral blood vessels can be seen. Grade 2, it is intermediate between grade 1 and grade 3. Grade 3 is the fleshy pterygium where episcleral vessels are not visible. There is an entity called pseudopterygium. Pseudopterygium appears as a pterygium, but there will be a strong history of chemical injury or preceding nearby ocular surgery in the past, and the pathophysiology is different. For pterygium, it is the degenerative process, and it is in pseudopterygium, it is the inflammatory process. And pterygium can be seen in both older and younger age. Most commonly in the older age. Pseudopterygium can occur in any age. Site pterygium usually occurs in 3 and 9 o'clock position in the palpebral aperture. Pseudopterygium can occur at any site. Progression: pterygium can be atrophic or progressive. but pseudopterygium is usually stationary. There is a probe. There is a test called probe test, where in pseudopterygium there will be a gap between the head of the pseudopterygium and the conjunctival base. We can introduce a probe inside the base, but usually this test is not advocated. Better to avoid this.
Tell you. You are very interested in probing, no?
No. No, ma'am. Books theory says there is
Yeah.
a probe test which differentiates pseudopterygium and pterygium, but it's
So if at all you want to do a probe, what will you use? What kind of instrument will you use? You should,
blunt.
yeah, make sure that you use a blunt thing and pass
Yes.
underlying. So normally what she's trying to say is there's enough morphological appearance that can differentiate a pterygium and pseudopterygium, and probe test is very theoretical. Maybe you can do it in the OT and don't try to pass it under a pterygium. So we are afraid of advocating a probe test because I don't want any one of you to go and probe underlying a pterygium. It will tear the tail and it will bleed, and the patient may also get very apprehensive. So if maybe you can use a bud, is a bud okay? Some bud is too big, I think. Something blunt you should pass.
It's basically the morphology and the strong history of chemical injury or surgery in the past will give you the diagnosis of pseudopterygium. Management, it can be medical or surgical. Surgical management is the gold standard management. Medical
Nothing
management,
like, is this a surgical treatment thing or is it a medical treatment? Like in ulcer is medically managed. If it's untreated, it becomes surgical. What about pterygium? How will you compare treat management of pterygium versus management of an ulcer?
it is based on the size and type of pterygium.
First, everything. It is a what was the indication that the patient we discussed comes to you? What is the patient's main problem who comes to us in the OPD?
Cosmetic.
Cosmetic. So for a cosmetic purpose, first of all, you will ask the patient, do you want surgery? Is it elective or emergency?
It's elective.
Is it not due tomorrow itself, right?
No,
so it's an elective
elective
surgery.
surgery.
And what is medical management? There's no medical management. It's only treating the ocular surface related problem. We didn't write that ocular surface problem, grittiness, pain. You wrote that?
Yes, ma'am.
Symptoms you wrote?
Yes, ma'am.
So most common symptoms apart from curiosity, what will the patient have sometimes? Foreign body sensation. Then he'll have what? Visual acuity problems. So these two you can manage by medical management.
Yes,
okay. If the patient has a visual acuity, it is encroaching upon the visual axis, or the patient has a cosmetic problem, then you will do surgical. So it's not first medical, then surgical. It's based on what the patient wants. Even if it is small atrophic pterygium, patients sometimes demand that to be removed. The third is one patient is going to have cataract surgery. Prior to cataract surgery, you want to stabilize the cornea by removing the pterygium to reduce the astigmatism. So you should know indications for when to do medical management, indications when to do surgical management.
Medical management, lubricants to treat the dry eye symptoms, topical NSAIDs, short-term used for short-term management, mostly not advocated. Others like decongestant and antihistamines are used in the pterygium cases by patients themselves by over the counter, and they are not advisable to use in pterygium cases.
Why it is not advisable?
Uh,
What
they
happens?
they are temporary. They will
They are temporary.
temporary.
Very
They will
good.
just remove relieve the symptoms at the time.
At the time.
They
Then
cannot use
after
life.
that, what happens? So they cause rebound vasodilation and they cause more redness. Then again person will again put the decongestant. So it gives a vicious cycle it becomes. It is common. Decongestants are sold in some places. So you should ask that history of use of
decongestants.
So that should be strongly be advised against, because they'll bring rebound inflammation. Then their next drug or go-to drug becomes topical steroids. Then these patients start using topical steroids also. Okay.
Yes. Indications for surgical management, cosmetic correction, and it is done before cataract surgery to stabilize astigmatism. If it is progressive involving the visual axis, if the pterygium is bulky, limiting the extraocular movements, or if it gives a suspicion of dysplasia or atypical features, and if it causes a higher astigmatism, even if it is not involving the visual axis, and other ocular problems like blepharitis, dry eye. As such, if the patient comes with all these complaints, we will go for surgical management. And as under surgical management, there are different procedures, excision procedures, closure procedures, and others. In excision procedure, we simply remove the pterygium if it is small, or sometimes simple excision will suffice. Bare sclera technique, I will be describing each in the future slides. And closure technique, it is primary closure, conjunctival rotational autograft, conjunctival sliding autograft, conjunctival limbal autograft, limbal stem cell transplantation, amniotic membrane grafting, and conjunctival autograft. Others like lamellar or penetrating keratoplasty, and the use of adjuvants in the pterygium surgery. This is the bare sclera technique, where the pterygium is excised and the raw area is left as such to heal by itself. The conjunctival epithelium will grow over the bare area, and the pterygium area will be covered by the normal conjunctiva. Primary closure technique, where the pterygium is removed and the raw area is closed by just pulling up the cut end of the conjunctiva from above and below the pterygial cut ends.
Why did they start doing primary closure? What happened? Initially, people all did only
Bare sclera technique.
avulsion, and they avulsed the thing, and they did only bare sclera. Then what happened? Why did they start closing?
Recurrence.
Yeah. So once the world saw the incidence of recurrence was there, then only all these they didn't come together.
Yes.
They came one after the other. First, initially, surgeons have done only avulsion and bare sclera. Then the underlying tissue was so they left very avascular area that caused more healing by secondary intention. A lot of fibrovascular growth took place. Somehow the primary intention healing didn't occur in these people.
Sliding conjunctival autograft, where the conjunctiva on one side of the cut end of the pterygium is pulled, just slided over the bad area and sutured. And the rotational conjunctival autograft, where an incision, relaxing incision is made to maintain the limbal orientation. Conjunctiva from the either upper or lower part of the cut ends of the pterygium is pulled, making a relaxing cut, and sutured over the bare area. Amniotic membrane grafting, where the pterygium is removed and the bare area is closed by amniotic membrane grafting, either with sutures or fibrin glue. Conjunctival autograft, where donor site is chosen, and conjunctiva is taken from the donor site, and the bare area is closed with the conjunctival autograft, either with sutures or fibrin glue. Steps of pterygium surgery. And a strict aseptic precaution, we give a peribulbar block for pterygium surgery, and speculum is applied. Superior rectus bridal suture or corneal tractions to suture for exposure, depending upon the surgeon's choice. And excision of the pterygium is from the head end near the limbus, and it is peeled with the beaver's microblade as a whole part, as a in a single piece, without leaving any ragged edges or tissue behind. And the area over the cornea is smoothened with either burr or buckle blade. Deep dissection of the conjunctiva, subconjunctival tissue is done to remove the tenons from the pterygium.
All of you will be assisting any one corneal surgeon, and each one will have a different way of thing. The main step that she's trying to say is that this one particular way is to remove it from the head end. There are people who go from the body of the pterygium and excises also. Both side thing. Only thing you need to do is make sure that it's the lymph, everything is free of the conjunctival tissue on the conjunctival side and on the corneal side.
The instruments used for pterygium surgery.
Just tell if you know the instruments. What is this? Scissors. There is a caliper.
Yes, caliper, universal eye speculum.
Universal eye speculum.
That is the 2 ml syringe for injecting balanced salt solution for getting the conjunctival graft, and this is the conjunctival marker. And That's a scissor for cutting the drape, and the hockey blade or buckle blade for scraping
knife.
the
Very
buckle
good.
knife for scraping the cornea, and it is a cautery some used for
Bipolar cautery.
bipolar
Wet
cautery,
field bipolar, you should say wet
wet
field
field bipolar
bipolar cautery. And cautery should always be minimum. Whenever you do pterygium
pterygium
surgery,
surgery,
you should do minimum cautery. Remember that. Okay. Yeah.
and the Carl's needle holder for used for suturing or superior rectus.
If at all you use
Also
superior
superior
rectus.
rectus.
Generally we don't. Then these are all micro forceps.
Forceps to hold the pterygium, and that is the conjunctival scissor to make cuts in the subconjunctival portion.
Okay.
And that is the that is the
End of
buckle.
the buckle blade is not very sharp.
Yes,
It's a little blunt only. That's why that is preferred.
buckle blade and the burr.
Diamond
The
polished burr this is. Okay, that is to smoothen the
corneal
corneal
surface.
surface of it. Why it should be smooth is basement so that epithelium will
Regrow.
slide better over even area rather than ups and downs. That's the reason why they polish the remnants of the
Corneal
pterygium
surface.
tissue over the bowmans. You should not go below the bowmans. Remember, don't go into the anterior stroma.
Yes,
Just in the plane of the bowmans layer, you have to peel the pterygium.
pterygium. Graft harvesting. Graft can be harvested in any site, either superior or inferior, mostly superior.
So you're telling surgical steps for primary pterygium or secondary pterygium?
Primary
So for primary pterygium, first you have told what is excision. Then you have showed the instruments for excision. Now you are going to talk about
graft
how to,
harvesting. Harvest the graft.
yeah, uh,
Close the
closure of the,
bare
yeah,
area.
the closure of the bare area. What will you do? That's what you're going to tell, right? Yeah.
Mostly superior side. If it's a recurrent pterygium, it won't be the superior side. And if a patient is planned for either a trabeculectomy or further procedures, superior side is left behind and the inferior side is preferred. The graft should be superficial, thin, and tenons free. It should be of adequate size, maintaining the limbal orientation, and the cautery should be minimal.
Why do we prefer superior or superior temporal side?
The lid will cover.
It is free from exposure because the primary cause itself is UV exposure.
Yes.
And also how much of conjunctiva we are able to get is more in the
Superior.
superior area. It's covered by the lid and also more thing. And also the tenons is less adherent in the superior area. Inferiorly, tenon is more adhered.
Securing the graft. The graft obtained is secured either with sutures or fibrin glue. A suture we use is 10-0 nylon sutures, and sometimes 8-0 vicryl is also used. And fibrin glue, we use fibrin glue here, superior to sutures in post-operative signs and symptoms. It is time and cost effective also. Um, and in the fibrin glue, there's one advantages of fibrin glue usage is less foreign body sensation, less hyperemia, post-operative chemosis, and other foreign body sensation is less in fibrin glue. But graft-related complications is comparably more in fibrin glue than compared to sutures.
Why do you think so? Just think about it.
Fibrin glue is biological or synthetic. If it's biological,
So what does that article say? It's got more
graft
complications.
related complications comparably more in fibrin glue.
So what can you imagine that to be? Either maybe that it retracts, maybe it's you tend to take a smaller graft, or it's not good enough. It's lost. The tissue is lost.
They didn't mention about
They
the
didn't mention.
yes,
Okay.
ma'am. They compared the post-operative symptoms in pterygium.
In these people's hands, that was the
Yes,
outcome.
ma'am. Yes.
Generally, it is very
Yes, ma'am.
uncommon to find. So the idea is
Complications in
to say that these two are
pterygium.
used,
Pterygium is
and
fibrin glue superior than sutures. I mean, both the time
the
as well as
comfort is
comfort.
far thing, and also you don't have that foreign body sensation with the which a
Fibrin.
suture gives. Okay.
Yes. Post-operative regimen. We use tapering steroids, antibiotics, and TS substitutes, and we review the patient the very next day after 1 week and 1 month after surgery.
So topical steroids is a must. You need to give anti-inflammation because this is thought to be inflammatory to pterygium itself, and surgical inflammation we do not want fibrovascular ingrowth faster, so we have to give steroids. So some of the authors have even given subconjunctival steroids like dexamethasone and triamcinolone.
This is a video showing pterygium surgery, biheaded pterygium surgery in right eye. First, the nasal pterygium is avulsed using buds and the forceps, toothed forceps, and the temporal pterygium is now avulsed from the head end near the limbus. And after removing the pterygium, minimal cautery is applied to decrease bleeding. And now the buckle blade is used to scrape the raw area of the cornea and the sclera. Now saline is injected in the subconjunctival space to harvest the graft. Here the graft is harvested from the inferior aspect using conjunctival scissor and forceps, and the limbal orientation is maintained. After securing the graft is split into two as it is a biheaded pterygium. One for nasal and one for temporal. The nasal aspect, it is larger, so it is used for nasal aspect. The fibrin glue is applied and the graft is placed over the raw area, and so, the graft is secured on the temporal aspect too. After securing the graft, the raw area created on the donor side is um, also opposed by using the same glue.
So it's generally recommended to close
Close.
the raw area because there the tenon will be exposed, there will be more inflammation. If you leave it also, the conjunctival epithelium will grow over it. But traditionally, we've been told to close all the raw areas. So we
Close.
cannot oppose limbus to limbus. If at all
Look at
you are very
steps.
keen, you can put a suture.
After the surgery, apidin eye drops is applied, and sometimes Ziploc eye ointment, pad and bandage is applied. Some prefer to use a bandage contact lens. This is a patient, 61-year female, presented with complaints of growth in right eye for 3 years to our OPD in October 2023. Her systemic conditions were normal, and on examination, except for the biheaded pterygium in right eye, other ocular findings were normal. Her vision was 6.6 with right eye 1.25 cylinder 80 degree and left eye minus 0.5 cylinder 100 degrees. She was using glasses. She was keen on removing her pterygium. The video shown prior is her video, and she got removed both the pterygium. And after 1 month after surgery, her astigmatism decreased. In right eye, it is minus 0.5 degree cylinder and 70 degree. The post-operative picture is shown here.
Her glass prescription showed a reduced.
Yes, ma'am. Complications of surgery. As we know, there are complications in surgery. Perioperative anesthesia complications, intraoperative complications, corneoscleral perforation in deep dissection, and if it is a wider dissection, rectus muscle can get disinserted, and graft related complication like tearing of the graft donors from the donor side, buttonholing of the graft if we take too thin graft from the donor side. Postoperative complications, early postoperative chemosis, corneal epithelial defects, hemorrhage or hematoma, blood collection under the graft, graft edema, graft rejection, graft loss or sliding of the graft, corneal scarring in the postoperative period, scleral thinning or ulceration, rarely corneal melting. And among these, blood collection or hemorrhage under the graft is very common. Late postoperative complications seen after a few months or few weeks or months, recurrence and surgery-induced necrotizing scleritis. Recurrence will be dealt in detail in the future further slides. And surgery-induced necrotizing scleritis is an immune-mediated reaction, mostly seen in other ocular surgeries also.
Where will you suspect if you see a patient of SINS? In the same site, you near the site of the surgery, you will develop this.
Yes,
So, what are the
features.
what are the questions you will ask if a patient has developed SINS And he said previously I had a growth there. After I removed that growth later on. So what is the leading question you should be asking as a surgeon, as a ophthalmologist?
Previous history of
Along with pterygium surgery, if uh, any medication, any substance was used, adjuvant, you put
adjuvants.
in your slides, no?
Yes,
The
ma'am.
third
Adjuvant
adjuvant
usage.
slide. What was the third thing? You put first excision, then you remove closure, then third
Adjuvants,
others. In that,
mitomycins,
so if your
mitomycins.
history of mitomycin 5-fluorouracil, you need to ask.
Yeah. In
The,
adjuvant usage in this
yeah, so they also can cause immune
since
mediated. Immune mediated, they themselves can perpetuate.
recurrence, it is mostly seen in the males um, above 40 years of age, outdoor working people. And if it is a progressive vascular pterygium previously, recurrence rate is more, and mostly seen in unilateral conditions rather than bilateral pterygium. And there is a surgical technique itself is a risk factor for recurrence. In bare sclera technique, it is most common, and it is lesser in conjunctival autograft. And if it is associated with other ocular conditions like symblepharon, recurrence is common. Treatment for recurrence. Recurrence is mostly seen in 3 to 6 months after surgery. Usage of adjuvant medications, as ma'am told earlier, will they
It can be seen within a month. If your glass appointment itself, you can see recurrence.
yes.
Okay.
Usage of adjuvants is also recommended to avoid recurrence. And conjunctival autograft is the superior technique to follow to prevent recurrence in pterygium
So
surgery.
depending upon the size and site and how much of conjunctiva is left over, whether you need amniotic membrane and you need mitomycin C, but mitomycin C is becoming again popular for recurrent pterygium.
Yes.
Okay, 0.02% you will use 0.02 to 0.04% for
Right.
not more than 2 minutes.
And there's a technique called the perfect technique used for recurrent pterygium. It is nothing but the pterygium extended removal followed by extended conjunctival transplantation. And we have to bear in mind if it is extended removal, muscle disinsertion is a complication. And a word about my fibrin glue. Uh, in SN, we use fibrin glue for securing the graft, and fibrin glue is a biological, maybe biological or synthetic. It has four components: the sealer protein component, and the solvent for it is the protein in solution, and the thrombin component, which is a powder, and lyophilized powder, and the solvent for it is the calcium chloride. And it's easy to remember, blue color bottles are mixed together and black color bottles are mixed together, and the solvent is used to dissolve the powder, lyophilized powder. It will be pale yellow or white in color, both mixed in separate syringes and connected to a common nozzle of the duplet injector. And before injecting, it is connected to the fibrinogen machine, and the first drop is let out without usage. And this fibrin component can be mixed. Each bottle, when reconstituted, comes at around 1 ml. 2 ml of fibrin is used. If we required, 4 ml can be used for the
So here we don't use the duplojet, we use it separately only.
yes. Amniotic membrane. In essence, we use preserved amniotic membrane, freshly prepared and cryo preserved amniotic membrane. And why amniotic membrane is preferred is it's a single epithelial layer, epithelium layered tissue, similar to that of conjunctiva, having same collagen composition, and it has growth factors and inhibitors for inflammatory conditions also. And it can be either freshly prepared or cryopreserved, lyophilized or freeze dried or heat dried. We use only freshly prepared and cryopreserved amniotic membrane here. And there are two types of application: either onlay patch or inlay graft. Onlay is the epithelium upside, and the inlay is the sorry onlay is the epithelium downwards, and the inlay is the epithelium upwards. That's the graft we use. In inlay technique, epithelium is facing upwards, same as that of the conjunctiva. It helps in the conjunctivalization of the bare area. And this is the ready-made available dried preserved amniotic membrane. And what about organ laser therapy for pterygium? A study conducted There is a publication on organ laser therapy for pterygium, where the laser is applied for the feeder vessel of the pterygium, 2 millimeter from the limbus in two parallel columns for the anterior ciliary artery, and the setting is as mentioned here, and it causes regression of the pterygium rather than decreasing the size. It causes reduction in the size of the pterygium, not
Any photos from the article? No.
no photos.
They were not there
No,
also.
ma'am.
Okay, because I didn't read about it, so I don't know if they didn't they published without any photographs.
Yes, ma'am.
Okay.
Other treatment modalities, these modalities are under study: collagen matrix implants, topical cyclosporins on the time of pterygium excision, gene therapy. As mentioned, it is the P53 mutation which lies in the pathophysiology of pterygium. P53 gene and its receptor is disconnected by the neutralin therapy. It's nothing but a gene therapy under study. And the expanded polytetrafluoroethylene, it is the Gore-Tex implants used for pterygium surgery. These treatment modalities are under study. These are my reference.